I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
I'm Dr. Randy Martin. I'm joined by Dr. Joe Wu from Stanford. Joe, good to see you as always.
Good to see you, Randy.
We've got a couple topics to talk about. So let's talk about and we talked, two of your colleagues have talked about the transcatheter or surgeon of the future,
yes.
Mitral surgeon of the future, that they're going to have transcatheter skills, interventional skills. What are your thoughts?
Well, there's certainly a lot of buzz around the interventional list. And whether that's approach from interventional cardiology or from surgery or from some sort of joint hybrid training pathway, it's very exciting. And it's certainly the way of the future. And I tell all of my residents and my junior faculty that this aspect of practice will be fundamental and integral to their future.
Okay.
Having said that, not every person needs to be an interventional mitral or aortic surgeon.
Right.
I think every group, every division, every department needs to have that capability, needs to have people who have that capability. But there will always be dinosaurs like me.
We need surgeons. No,
yeah. So I am not quite as involved in the transcatheter space. I like to try to drive the trials and the investigation, and certainly refer a lot of patients in for transcatheter devices, but I'm really not the one steering the wires and so on. I have young, talented surgeons who spend a lot of their time doing that, and I think that's perfect.
But to balance a surgical program, you need,
yeah.
I mean, I've always felt that you need, the good interventional surgeon will be the one who's been there and has had training in surgical care.
Right.
I think it's really important.
I think that'll help guide that individual along. Yeah.
Let me ask you, I've been a big proponent of the cardiologists historically have waited too late to send patients for mitral valve repair. They waited for symptoms, AFib, LV dysfunction, those sort of things.
Right.
Where do you think we stand? What do you see in your practice?
Well, that practice was guided a lot by the outcomes, the perioperative outcomes, the repair rates, the durability of the repairs. All of those have improved significantly. So surgery, heart surgery, is so much safer than it used to be. Our repair rates are much higher. These repairs are durable. So I do think that as the guidelines have shown over time, the thresholds have changed, going from 2B to 2A recommendations for asymptomatic severe MR. I think that trajectory is going to continue heading in that direction, that we're going to operate earlier and earlier in the time course of the disease process, and probably intervene on even less severe disease. I think it's incumbent upon the surgeons and the interventional surgeons to deliver perfect repairs at an extremely high rate. I'm not even sure that the guideline mandated level of 95% repair rate with less than 1% mortality is good enough. I think nowadays a typical cardiologist probably does not expect 1 in 20 of their primary MR patients to come out of the OR with a mitral valve replacement.
Right.
So I don't think 95 is good enough. I think we need to be much higher than 95. So I think that's an issue, and I think that's the general direction we're heading.
I hope so, because I think that as you've improved surgical techniques and durability and outcomes, and I think moving earlier in the asymptomatic patient before their ventricle or their atrium is damaged by the process is really important. And then, Joe, you told me some really interesting, fascinating stuff. We were just talking a moment ago about what you're doing at Stanford to look at the valves a little bit differently. Tell me a little bit about that.
Well, we're working closely with the mechanical engineers and designing 3D printed devices that are currently allowing us to study the fundamental biomechanics underlying mitral valve diseases and the operations that we do to repair these diseases. So, for example, most of the operations that we do are based currently on the anatomy,
Right, right.
the appearance when we're doing the operation, and then the echocardiographic result,
Right.
and then the long-term durability. But we've never really studied the underlying biomechanics, the forces in the cords, for example, or the stresses on the leaflet
Stresses on the
surfaces,
leaflet, sure.
or whether or not adding additional cords changes anything in the papillary muscle.
Cool.
So we have a variety of tools now that we're using to study all of these, and some of these are in the process of being published.
Cool.
Basically trying to guide these operations, and it's actually very interesting. Some of the findings that we've obtained from these biomechanics studies have actually guided how we're doing our operations at Stanford.
Interesting, interesting. I mean, you could envision this, and I know there's you would think that looking at the different stress points on a valve beforehand would tell you what you might need to attend to, or how you might need to reinforce things, or cords, or things like that. Is this something you think will become? I mean, you've got obviously expertise at your hands at Stanford, but is this something that you think will develop so it becomes relatively routine in the years, or more frequent in the years to come? Because it seems tremendously valuable.
Yeah, well, we hope so. The first study that's actually in the process of being published is on valve-sparing aortic root replacement.
Cool.
And we've looked at different graft configurations. And based upon that, I've already altered how I do my operations.
Interesting.
Yeah,
Interesting.
So I think it'll be much more widely accepted.
I had asked you earlier, but there's been a lot of interest in, we as cardiologists we think the mitral valve opens and the blood fills into the ventricle, but there's a certain pattern the way that comes in. Do you think the importance of looking at that pattern after mitral valve procedures is important to look at ventricular function?
Right, exactly. Yeah, there's a certain clockwise versus counterclockwise flow of blood in the ventricle, and preserving the natural flow probably makes a lot of sense. And I think using 4D flow and things, technology such as that, will help guide our operations as well, and our transcatheter device development.
Let me ask you the final question is, if you had to put on, and Mike Mack talked this morning about mitral valve surgery in 10, 12, 15 years, where do you think we'll be in 15 years?
Well, I don't want to bet against Mike Mack,
Or you
but
can.
I actually think that while there will be rapid expansion in the number of devices, transcatheter devices, and also the efficacy of those devices, I think surgery will continue to evolve and improve, and I'm not so sure it's going to be 3/4 transcatheter and 1/4 surgery. I think it's going to still be a fair amount of surgery.
Good. I hope so. I mean, from my early days when I trained at Stanford, surgeons became very special to me. Cardiac surgeons did. So, Joe, thanks very much.
Thank you.
I've enjoyed it and learned something. That's really great.
Thank you very much.
And thank you for joining us.